Hello and welcome to today's webinar on value-based care transformation through collaboration. Thank you to the Healthcare Executive Group for the opportunity to share our knowledge around this topic with all of you. Change Healthcare has been a partner with the Healthcare Executive Group for many years. Today's presenters will be Norberto Correa, Consulting Director of Value-Based Care. Mr. Correa is a seasoned healthcare executive with 30 years of varied experience in the academic, hospital, and managed care business sectors. His executive roles include health plan CEO, health plan COO, and IPA president. His areas of expertise are integrated healthcare delivery systems, information technology, health plan operations, value-based payer, and provider models. He has developed and deployed population health and value-based reimbursement model strategies that include ACO, IPA, risk, and shared savings Medicaid and Medicare payer networks. Our other presenter is Mary Brannigan, clinical consultant with our population health practice. Ms. Brannigan is an experienced clinical informatics specialist with over 30 years of payer and provider experience. She has provided guidance to leadership and clinical teams in redesigning programs to meet mandates of healthcare reform and new reimbursement models to optimize person-centered care. Her expertise includes data integration and change management strategies in new and emerging models of care. A couple of administrative notes before we get started. We will have time for Q&A at the end of the session. If you have questions, please submit them via the Q&A box, which can be found on the top right of the menu, or directly through the chat box. If you encounter any issues, please contact the host directly through the chat window. This webinar is being recorded. The recording and slide deck will be made available to registrants within 1 week. And with that, I will turn the webinar over to Norberto to introduce today's topic.
Thank you, Stephanie, for that introduction, and welcome everybody to today's session. As a result of the time that you've invested with us today, we'd like to make sure that you walk away with three key things. We'd like to make sure that you have an overview of the transformation that's underway in our industry to transform our industry from paying for volume to paying for value. The second key insight we'd like for you to take away is an understanding of some of the collaboration that's occurring in our industry, collaboration between payers and providers mostly, but also the impact it has on our consumers. The third piece of information we'd like for you to take away is really not information, but we'd like you to ask your question with respect to your organization. How do you feel the role of your organization is positioned to successfully support the transformation that's undergoing, and what are some of the things in your organization that you should be paying attention to? So transformation is occurring throughout the healthcare industry. It has been ongoing since the mid-90s with the advent of managed care. It has subsequently become more of a rapid transformation due to some of the forces that are impacting our industry, forces around the consumers, for example, the high cost of premiums and the continued increase in premiums, although at a more bearable rate is still occurring. So that brings a cost and a quality consciousness to the consumer. And then the advent of technology is another piece that has been at play here recently. During the mid-90s with the advent of managed care, we didn't have a lot of the technology we have today, so this really helps engage the consumers. The other aspect of the transformation is based in the provider sector. Providers are continuing to struggle. The smaller providers are continuing to struggle with value-based payment transformation, and so they're finding a way to, they're looking for a niche. They're looking for a way to get engaged. The larger systems and provider groups are continuing to progress faster than the independent providers because they have the capabilities and the infrastructure to do so. And then the other aspect, obviously, is the payers. There's continued regulatory requirements, there's shrinking margins, and an increased number of complex chronic members that are impacting their payers' cost structure and ultimately their ability to succeed. thus producing the need for narrow networks and also the need to put together an infrastructure to support quality and cost performance. It's all really driven to create a better, more value for the dollar. Some of the macro trends impacting payers are listed below. Some of the trends around care coordination across different entities, so coordinating care between the payer, the provider, and the patient is something that's really critical to achieve some of the goals payers have set to achieve the cost and quality outcomes they really desire. Patient-centered model is a big thing for obviously not only the consumer, but also engaging the patient and really driving that outcome that we want. So better quality, lower cost, and an overall wellness for the member the payer served and for the patient that the providers see. The growing emphasis on data analytics and emerging technology has really emerged within the last 5 to 10 years and is driving a lot of capabilities that payers have today to do population health management, stratify their membership, and really manage cost. The risk pool and risk adjustment, as always, is important to making sure that the reimbursement at the payer level for the right benefit structures is being achieved. And the cost reduction pressure is an ongoing pressure, and it's driven a lot of payers to really look for ways to partner with providers and even in some cases with other organizations in their community network to really put together products that are cost affordable for the members and also that can help them achieve the margins that they need to maintain. And demand for quality and cost transparency is ever more increased today because of the availability of the technology that we have to produce that transparency. It's even more key. And then the increased government regulation, aside from ACA, there are other factors from a regulatory standpoint that are impacting not only the payers, but also providers and consumers as well. So what is the state of transformation today? Well, a recent survey by ORC International really kind of lays it out. Payers are continuing to drive towards that value-based reimbursement. 58% of payers surveyed said that they already had shifted to a value-based reimbursement structure. They also are deploying a mix of value-based reimbursement and fee-for-service. So 97% payers say they have some kind of mix. And typically, it's really driven by the size of the organization, and it's driven by their ability to aggregate membership and provider networks to support the delivery of quality outcomes and at a cost that's affordable for the member and for the payer. And then 50% of providers today that were surveyed have already shifted their business to value-based reimbursement. It's still a transformation. The availability of technologies at the provider level in the provider office still has a way to evolve to achieve and increase these numbers because providers are struggling today with just maintaining their cash or fee-for-service business versus how do I get into a value-based reimbursement structure that's based on a payment that I will see in the future. Medicare shared savings program, ACOs, have seen a growth. Since its inception, it's delivered a savings of $1.3 billion since 2012 for the MSSP ACO. There are more providers, ACOs, that are taking downside risk. In other words, they're accepting responsibility for any financial losses they incur as a result of being in an ACO model. Next generation ACOs are important. They're the next evolution of the pioneer ACOs that existed and that have really transformed into a next generation ACO, which they are really taking significant downside risk or significant risk for the financial losses. Nonetheless, the growth, in spite of the risk will continue. ACO growth is going to be continue to be driven by MACRA, which is the Medicare Access and CHIP Reauthorization Act. This is driving providers to seek two different models. So they either migrate into a performance reporting-based model or they migrate into an alternative payment model. ACOs are an alternative payment model that will be there for providers to migrate into. So they will continue to grow. Currently, Medicare Shared Savings Program ACOs cover 9 million Medicare beneficiaries, and there are 525 ACOs in 2017. The future of alternative payment models, as I mentioned, plays a key. Developing the next generation accountable care organizations will drive some of that membership into these ACOs and will also facilitate shifting of financial loss risk to provider groups, which can manage that risk. The impact, as I mentioned, of MACRA is critical because providers will have to make a decision between being in an APM or joining the, continuing to do the quality, pay for quality and reporting programs that are out there. Payer and provider innovation will continue. Last few years I've seen an increase in payer and provider joint ventures. I've seen a proliferation of collaboration to form ACOs between payers and providers or individual provider groups or hospital system providers. And the other key is data exchange and the operability. The key to driving these quality outcomes and to managing cost is exchanging data and to allow sharing of that data between those individuals in the delivery system that are responsible for managing an episode of care and driving the quality outcomes. So as I mentioned, Mary is going to talk a little bit about our drivers, but as I mentioned, that transformation is continuing, and these are 4 key areas of that transformation. So Mary, if you could go ahead.
Sure. So many of the drivers of value-based transformation are related to the patient and the patient experience. Patient experience has become more and more important, not only because of the availability of different tools and different apps and access to systems, but also because of the consumerism that is driving healthcare. Many folks did not realize they were actually going to be able to get in the market, and some have been market entrants by surprise. For example, I have friends in my in personal experience where our parents were put into the market without knowledge and had to become consumers due to changes in how retirement plans are being operated. So some of the retirement plans that have been available for folks over time shifted to the market last year, and folks became consumers without really being prepared for that. Mobile technology has also been a big player in patient experience, and virtual visits, access to providers through means other than just an office visit is driving this. Another thing that is driving the transformation is, as Norberto already mentioned, MACRA, or now the new replacement for meaningful use, which is driving different incentive programs and different ways to document quality. And so you have many payers and providers trying to operate in a system where they need to share data, and they also need to report on specific metrics, but the metrics don't match each other across the board exactly. STARS measures are different than what might be chosen for a MIPS metric, and so everyone's trying to really get their arms around this. And then, of course, everyone is used to the HEDIS data set and the requirements that are needed for good HEDIS scores and results. And so it's putting a lot of pressure on systems to transform the way they do business and how they share information.
So,
Go ahead.
So, Mary, as you mentioned, the big piece of it is the STARS program on the Medicare side, but there are also other quality reporting requirements that some state managed care organizations are under pressure to achieve. Just wanted to mention that.
Yeah, so, bringing all of this together, too, is just using your predictive analytics appropriately and being able to determine what groups of people that you want to be working with and how you're going to be able to translate that into all of these other driving forces. The predictive analytics can be used in many different ways to determine if you want to look at certain populations of patients to manage and then how you manage the population overall. And different groups, the providers and the ACOs and the payers are all using different analytic platforms and different analytic algorithms, and so all of that needs to match across the board. So it's forcing collaboration. The Medicare Innovation Center has put out some documentation on programs that have been successful through funding, and we'll need to find ways to make those sustainable. Health information exchanges have become a big part of this as providers are seeking information from the HIEs and sharing information through them. ADT messages and other methods of communication between payer and providers are now available that were not available in the past.
So what does that mean for payers? Well, payer readiness to support value-based care is critical. It's really how are payers ready, to align resources to focus on the patient. Most payers are in some type of transition. They're transforming their organizations from a siloed care model into more of an integrated care model that integrates, integrates the not only the health plan functions internally, but also the external provider functions and the patient engagement to really scale effective interventions to impact their patient population. The ability to aggregate and analyze data across the healthcare network is extremely important. As Mary mentioned already, just the predictive analytics and some of the patient management, but also just to become a more informed network of deliver services. The data and information shared between the provider and the payer and the patient is crucial to managing patient outcomes. And the integration of some systems within the plan is another place that has to undergo some transformation and is going some transformation. Being able to integrate financial and clinical information onto one platform to manage not only the patient across care settings and over time, but also the value-based payment that goes with driving those outcomes is really important, and many organizations are investing significant time in doing that. Recognizing the structure, the institutional structure for value-based payment is really different than today's fee-for-service world. Moving from a transaction-based health plan to more of a transformation enabling health plan is a big step and could involve restructuring of staff and units within their organization. It could involve developing new roles and developing new staffing models to really work with and identify with providers changes to reduce cost and boost efficiency in the system overall. Physician engagement is another critical component. Obviously, setting common goals and really having the right incentive structure is key to achieving those goals. Engaging the physician leaders, there have to be physician leaders not only within a payer's organization, but within a payer's network for a payer to be successful in implementing some of the goals and some of the programs that needs to implement. And then new clinical and operational processes have to develop, to really, and they really need to develop to sustain care long term and really behavior change. The days of health plans calling members to follow up on different things are changing to the provider engaging the patient at the point of service, and the health plan helping them, the provider, achieve the goals the provider has set for them in their patient care plan.
So all of this requires a good population health model and approach. And central to that is the care team. And many of the different entities, hospital, provider groups, health plans, have had their own care teams, but now we're needing to integrate the care teams across all of those settings and actually into just the patient experience with health behaviors. Pharmacy data is important to keep in mind as the care team is looking at managing care. And we've all heard a lot in the past months about medication reconciliation and how important that is and how that leads to much better care, not only financially in reducing duplicates of drugs, but also in the safety of the patient and how they are managed overall. Another piece of that is utilization and transitions of care between settings. And so there's been focus on changing some of the care management strategies and care teams to align better so that there is not just a paper process of following people through one part of the system to the next part of the system and then dropping off after 60 days with the check mark that has been done. So we need to be able to integrate throughout the entire lifespan of the person how we manage the care, when they're well and when they're not well. Predictive modeling to stratify the populations that you want to manage is, as we mentioned, important because we want to be able to identify early folks who are at risk. So pharmacy can play into that, and which you get claims or authorization requests for certain medications, and you find out that perhaps someone is a dialysis patient or someone has HIV, and that may be one of your populations that you're following. But it's also important to keep in mind the populations that are at risk and not sick yet, so that you're able to intervene as the care team in a different way. A lot of the care teams have been focused on just the critically ill or certain populations, but as we roll this out, we realize that people transition between being critically ill at some times and then getting well and then coming back into the system with other risks. And so it takes a lot of finesse in figuring out how we manage all of this and how we align the resources that are available at the provider sites and those resources that are available at the payer, while also making the atmosphere such that the individual or patient can participate in their care. This really is important that you have a great network of physicians and engage the physicians, and that means that the payers need to do more for the providers, and the providers need to do more for the payers in this model of care. It cannot operate separately, and it involves sharing information with one another and sharing information in meaningful ways so that the providers can actually use the information available to provide care at point of service. Next slide. So again, this is really all a 360 degree pulse of a person, and I go back and forth between saying patient and person because we really want to be working with folks before they become patients. We want to be able to prevent the morbidity and the mortality of the entire population, and so we want to be looking out for how we intervene, and that requires that we as health plans and we as providers give information back to consumers, patients, individuals, and so that help them manage their own care. And patients are beginning to demand this. The care management programs are not the same kind of programs that we saw in the past, in which only the sick of the sick is managed, but people are fluid throughout the process. And in order for that to happen, performance dashboards need to be available so that providers, care managers, whoever's interacting with the patient, oftentimes there's many other people involved in the community that if they don't have information that's available to them in order to guide their actions, then we find duplication in efforts and also missed opportunities. And so the PCP engagement and the two-way interoperability are really critical in terms of being able to make that information flow. And the way it's designed and the information is presented is important so that it's actionable.
So the transformation between from paying for volume to paying for value is really one that requires a good decision support system to allow the exchange of information between the health plan and those entities involved in delivering patient-centered care. You know, the behavioral health providers must be connected to the community-based care providers and the integrated care team. And the patient obviously is at the center of that, and the physician is driving the point of service engagement with the patient. Now, health plans, as I mentioned earlier, will undergo a shift from being more transactional to being more supportive of the transformation. And to do this, they need to push information through some type of decision support system. The value-based payment mechanism that a health plan puts in place obviously requires systems to support that and exchange the data through some type of decision support system. So what does that mean? So health plans data infrastructure that supports the decision support is really based on a health information exchange. So the use of integration engines and patient registries and clinical data repositories within that information exchange, and which ones are chosen by a health plan or an entity, any entity, it could be a provider organization, an ACO, is really crucial to really providing the right and complete continuous care document to the providers, either through a portal or directly through bidirectional exchange into their EMR system, and also the risk stratification data that the provider needs. Now, there are various models. This happens to be a model that involves a hospital and a plan system, but different components of this data exchange system can be removed or added based on the level of complexity of the population and also the providers engaged in the sharing of the information. So the next slide speaks to the value-based model and interoperability. And Mary?
Yeah, so again, this discussion around, the interoperability that's necessary in order to exchange data and the role of each one of the components within this. So there's the patient who needs to be engaged, and the information that is shared needs to be on a platform that enables the entire care team to see the information that's there, and also allows the patient or member to engage with the system. The patients, in order to be accountable, need to have two-way communication as well, so that when they're putting information into a system regarding their health and well-being, their A1C measures, their blood pressures, they're getting some kind of feedback in return that tells them how well they're doing. And we all know about the monitors that we're all using now on our wrists and our phones and everywhere else that count our steps. And those pieces of information are very important to folks as they reach goals and make goals. And health education materials need to be available in order for individuals to make good choices on the types of nutritional support they want, on the types of different treatment methodologies that they want to be utilizing in order to augment their care. So many folks are opting for things like acupuncture and massage therapy or yoga and stretching, other less traditional methods of treatment for very common problems. A lot of the GI problems that people have experienced, they've been going to probiotics and other kombucha and other things that are used by naturopaths or just out there, information that's out there. And so we have a hungry population of people looking for ways to manage their care, but that information needs to be fed back into the system as to how things are working and how people are using these interventions and what's working, what's not working overall. But the member is now very, very eager, in most cases, to engage, or more so the generation coming up, and also many of us who are taking care of our parents in this age, and that we are hungry for the ability to be able to communicate with providers and get information that we need about processes that are going to support the rest of our family structure. The continuity of care is been helped with the CCD, the advent of the CCD, and the team will use continuity of care documents to plan care. I know through HL7 there is work being done on a continuity of care document for a care plan that will allow many people to participate in the plan of care. But right now this is a difficult thing to do because there are separate care plans in multiple different areas where an individual is receiving care. So there's care plans at the provider level, there's care plans at the specialist, there's different interventions that are done in each one of those areas, and there's no communication across the spectrum. And so as we move towards more of a person-centered approach, we need to be able to figure out which elements of information are important to track, at least from the beginning, because there's so much information out there and so much data out there that to try and bring information systems together right now requires a lot of effort and coordination. So more to come on that, but as the payers and providers, work through these and look at how they can close gaps and align their analytics in order to choose the populations to work with and demonstrate, through report cards and other methods, how well folks are doing, we really won't know. So time will tell as to how we can promote the model through this interoperability and improve the quality outcomes. Next slide.
So what does this all mean and how does it all come together? So as I mentioned earlier, value-based care encompasses value-based payment, and there are several models of value-based payment out there. And some of these have evolved since the early, late 90s, and some of these are recent. They essentially fall into three categories. The first category of models seeks to transfer risk or financial losses to providers. The second category is incentive-based payment, essentially. They either pay for quality or they pay for performance. And I'll go a little bit more into detail on them in a minute. And then there's obviously the traditional fee-for-service. So what does that mean to the evolution of these models? What does that mean for us as an industry and the systems required to support these models? Well, they have to be systems that allow for data integration, number one, because as you increase in the model of complexity, you also increase not only the market innovation, but also the transformation of any financial losses that go with that. So you have to have systems capable of not only supporting the patient-centered care, the integration of data not only within the plan, but the integration of data across a network of caregivers. It could be community-based givers, it could be primary care offices, it could be the hospital and the health plan. So this is critical to the success of the evolution of any provider within a network that's wanting to make that jump from a fee-for-service world into one that's based on total quality outcomes and that also manages costs. So that data integration and collaboration really facilitate that transfer of risk. This was initially seen in the Pioneer ACOs. That demonstration ended in December of 16, but that was replaced with the Next Generation ACOs. These accountable care organizations really are going to drive some more of the success for that Medicare program because it really is going to continue to aggregate more Medicare recipients and more Medicare providers into these ACOs to drive the outcomes. the Medicare Shared Savings Programs, the higher level ones begin to shift some type of financial loss down to the providers. It's not as much as you would see in an accountable care model that's a global ACO, but it's a percentage based on benchmarks that Medicare has set. MACRA, with the elimination of the sustainable growth rate and providers no longer being able to count on fee schedule increases year to year based on the metrics that were set, it's going to drive them to, as we mentioned earlier, to provide a quality reporting system like MIPS or to some other type of alternative payment model. And, so from a Medicare Pioneer standpoint, that was a successful program. A lot of the Pioneer ACOs that originally were started ended up dropping out. There were 19 that remained as prior to the shift over to the Next Generation ACO, but a lot of those stayed in the the Next Generation models. As I mentioned, Medicare Shared Savings Programs 2 and 3 will continue to grow as providers are more apt to take downside risk and accept financial losses. Medicare Advantage is another area where there are providers within Medicare Advantage that take risk, that are large enough and have enough patients throughout the network for a health plan to accept that risk and to manage that risk, and they have the capabilities to do so. We'll talk about one a little bit later. Medicaid is also starting to see a proliferation of some of these ACOs. I believe there's 30 Medicaid ACOs across the country, and that number is growing. And then commercial ACOs are also flourishing. We'll talk about an example later on as well. With regards to the incentive-based payment, medical home, there are 4 different levels of certification and required certification, but there are a lot of plans out there that are engaging with providers that are either certified or not certified, and they're moving towards getting them certified. So that's a continuing evolution that's going to continue to take place. Pay for quality around the HEDIS measures and also measures set by the states in their contracts with different Medicare medical care organizations. It's going to continue. They essentially are a replica of what HEDIS does, but they add some state-level measures into their reporting matrices. Pay for performance includes the bundle payments. Paying for episodes of care is something that's also taken off. Not everybody is able to process those bundles yet. Not everybody has the network to do that, but there's a lot of interest in this area. And then, as we mentioned earlier, MACRA around the MIPS, essentially the combination of various reporting programs that existed before into 2 or 3, and including meaningful use, basically require the provider to continue reporting. But in today's world, in 2019, I believe the providers will start being docked for any deficit in their reporting measures. And then the advanced alternative payment models are the ones we were talking about: MSSP, Medicare Shared Savings Program, Next Generation ACOs. Primary Care Plus is another program that is evolving as well. And then a care model around EARD patients. So these are end-stage renal disease patients that have basically been grouped into this care model, and there are providers that are taking risk for managing those providers. So what does this mean? There's, as we mentioned earlier, provider engagement is key, in my opinion. Aside from the data integration and the interoperability, provider integration is key. The way to look at the market today, you could essentially look at it and group providers into 4 main buckets. The first bucket would be those providers who we know are working hard and doing the right things, but will never have the size of membership, will never have the infrastructure to support anything other than fee-for-service. And they could essentially be on a pay-for-quality reimbursement mechanism. They want really to stay where they are. They feel more comfortable where they are, but they want to do the right thing for their patients. Model practice are larger practices. There's usually a membership threshold around 300 to 400 members in a practice that these provider practices are reimbursed on quality measures, and the provider practices may share in some of the savings as a result of the work they're doing with the patients and managing the population. And these are providers also that typically will align with other providers in a bundle payment arrangement. Patient-centered medical home, as I mentioned earlier, these providers typically are certified and they get recognized for that certification. They have clinical and quality measures in place already, and they're getting reimbursed for those measures. And they have an ability to be in a shared savings program. And in addition, they would get a monthly per member per month payment for coordination of care activities. And again, these would also have a minimum membership threshold that most payers look for. And then the most engaged and the one that really I see as providers on the cusp of doing some of the things that are needed to transform our system are the ones that are in accountable care models. These are typically providers that have infrastructure and have the ability to manage global or full risk. They can or share risk. They have the ability to track and manage any surplus or deficits that occur as a result of the contract. What that means is that if a provider is paid a certain amount to deliver care, if a provider group is paid a certain amount, and they provide care and it costs more than the amount they're paid, they would assume that risk completely or partially. And if they provide care underneath the amount they were paid, then obviously they would either share that surplus completely or partially, depending on the contract that they're in. Now, this requires a lot of infrastructure, and it requires providers to have the ability to exchange data and also do the analytics required to manage the population within their network. These are providers that are high-performing practices, usually with larger panels, and engage in routine performance reviews with their payers. The smaller providers are what I call transformative providers. So they're undergoing some type of transformation. Those transformation providers are the ones that I described in the first three categories on the slide. They're smaller practices, but they want a path to get to the next level, so a path to risk, and typically are engaged with the health plan in finding ways to do that. So some examples of collaboration that are happening are really, first example that I can see that really fits what we're talking about today is CMS's practice transformation networks. So this is a result of ACA. $500 million were put out there to form these practice transformation networks through the Medicare Innovation Center. So these are organizations that are working with individual practices to facilitate the transformation. They're doing an assessment of the practices, they're providing the tools providers need, and they're helping them get to the next level. This was started ahead of the introduction of MACRA and is continuing today. I think they're in the second phase. Another example is a local plan here in the Phoenix area, Scottsdale Health Partners. This is an integrated network that also engaged as an MSSP and then subsequently became an ACO. They were able to see an 8% cost savings on all lines of business on 35,000 Medicare lives as well. And so they've been successful with doing some neat things like Tiger texting to support their care coordination efforts and data sharing using a system that they call Care Connect to exchange that information between their hospitals, their integrated physician practices, and then their staff practices. And then obviously another successful organization here in Arizona is the Banner Health Network. This is a large multi-tier network that consists of a collaboration between a PHO, staff providers, and an IPA. This has been ongoing for some time, and their first real endeavor into collaboration was around their Pioneer ACO lives, around 59,000 of those lives. They're the most successful Pioneer ACO. They were able to achieve $35 million in savings in 2016. And then another example is Aetna and Baptist Health and the commercial ACO that they formed down in Jacksonville, Florida, Florida to cover Baptist Health Associates and an ACO model. So
in the end, there are several keys to success, and what we're really looking for is a win-win-win, win for the patient or the person, win for the provider, and win for the payer overall. And so that requires many of the things that we've already discussed here. A good provider engagement strategy, often led by a physician who is definitely understands all of the concepts that we've been discussing today and how that impacts their organization, and is able to collaborate with the health plan. We need that patients engaged in their care and education, but we also need a two-way street of feeding information back to them that allows them to take care of themselves in the best way. And communication between the providers and the patients in terms of the ability and ease of doing that. So breaking down some of the barriers and using the technology that we have available that promotes that. And it's one thing to build a program and create interventions. It's another thing to individualize all of that. And different groups of people will prefer different ways of communication. Some will prefer text messaging. Some will prefer visits in the office. Some will prefer using video chat with their providers, and I think we're going to have to be open to all of this. And part of what needs to support that is the payment model for this. So how do providers get paid for this care? They've actually really been doing it for quite a while. The other piece is how do we get that documented into a record in which everyone in the care team can see and participate in, so that we understand what's happening with the person as they flow through the system. And that's really a requirement of this interoperability that we have now. How will we make this happen, and what systems will we use in order to capture the large volume of data that's being developed today? And governance will be another big part of that, is how we define certain things that are pertinent to the care that we're giving and make sure that we're talking about the same things across the board. So we need to be able to create very innovative models and think outside the box, and start thinking all over again, so that we have this win-win-win and the ability to promote the triple aim.
So what does that mean in the long run? In the long run is that the transformation is going to continue. I think it's been put in motion a long time ago. I think technology and the need based on cost and the drive for quality is continuing. And what's new to the equation is really the engagement of the member or the patient, and the technology to allow them to engage. I think in the long run, we'll see something that's much different that we're used to seeing. And so, having said that, I'm going to just say this: I appreciate you guys joining. I hope that we gave you an overview of the transformation that's occurring and that it was clear. And I hope that you have a little bit of insight as to what's going on out there. It's impossible to capture everything that's happening. There's a lot of innovation and a lot of work that's happening with respects to provider engagement, with respects to technology and payer transformation, not just provider transformation is occurring. And then there's a lot of partnerships that are springing forward from that. So the other thing is, I hope that from this, you're able to define a role for your organization. And I just want to add that we at Change Healthcare, we do a lot of work around these areas, whether it's population health, whether it's value-based care transformation. Our consulting services are really partnering with different payers. So we're part of that change and we're part of that collaboration.
Since we are up almost at the top of the hour, I want to take a moment again to thank the Healthcare Executive Group for this opportunity, and to thank Norberto and Mary for your presentation. It was fantastic, a lot of great information there. And if you'd like to learn more, or if you have further questions about today's material, you can reach out to Norberto and Mary directly via the contact information that's included in the presentation. So thank you again, Norberto and Mary, and thank you to everyone that joined us, and have a great rest of your week.